It's really exciting to be able to see how we're taking research from the bench to the patient's bedside, right? The bench to bedside approach, and really personalizing treatments, not only with our therapeutics, but also our non-therapeutic approach. So supportive care for patients, making sure that we're taking care of, I tell my patients this all the time, mind, body, and soul, right? Really focusing on the whole patient and seeing how quickly these advancements are happening and really being able to bring these advancements into clinic for our patients was rewarding and what motivated me to go into oncology.
Hi, I'm Bisma, and you're listening to The Other C Word, a podcast about all things cancer from a stage 4 breast cancer warrior. We cover health and wellness, mind, body, and soul. Plan to leave each episode with hopefully some new insights and inspiration. Let's get into this week's episode. Welcome back, everyone. I'm so excited for today's guest. We have Dr. Eric Singhi here with us. Dr. Singhi is a medical oncologist treating lung oncology. He focuses on personalized care and advancing treatments to improve outcomes for lung cancer patients. Dr. Singhi, welcome to the pod. Thank you so much for being here.
Thanks so much for having me. Excited to be here.
Thank you. I'm honestly super excited to have you on. So as I have told you, I was diagnosed with metastatic breast cancer, and we do talk about breast cancer quite a bit on this podcast, but my goal really is to have this be a widespread cancer community. And I think there's so many commonalities with living with cancer, whether it's, breast or lung or colon, whatever it is. Of course, the treatments vary, but the overlap of side effects and then the mental and emotional impacts, I think, are very similar. And so I'm really glad you're joining us today. And I'm looking forward to learning about lung cancer and your work. So maybe we can start off with what inspired you to pursue lung oncology.
Yeah, I think, cancer is such a personal experience, but it's one that all of us have, right? We've got family, we've got friends, we've got loved ones who've been diagnosed with cancer. And so we've all learned not just the physical toll that it takes, but the emotional toll that it takes. And so that was a very early sort of entry into the world of cancer for me. And then fast forward to thinking about what I wanted to do with my life. My grandfather was actually a family physician, and he would talk a lot about the patient physician relationship, what it meant to him to not only treat the patient, but to treat their family and really have that experience as being there for patients in a longitudinal way. And so that really sat with me. And then I went to undergrad and started learning more about pre-medical studies, got very interested, ended up going to medical school. And then actually during our didactics, I learned about so many different advancements that have happened specifically in lung cancer. It's really become this poster child of precision medicine, which we'll talk more about. And it's really exciting to be able to see how we're taking research from the bench to the patient's bedside, right? The bench to bedside approach, and really personalizing treatments, not only with our therapeutics, but also our non-therapeutic approach. So supportive care for patients, making sure that we're taking care of, I tell my patients this all the time, mind, body, and soul, right? Really focusing on the whole patient and seeing how quickly these advancements are happening and really being able to bring these advancements into clinic for our patients was rewarding and what motivated me to go into oncology.
That's awesome. I actually haven't heard that. You said bench to
Bedside. Yeah.
bench to bedside. That reminds me of farm to table. Is that kind of the...
Yeah, pretty similar. A slightly different approach, but about the same metaphor.
Yeah. Okay, great. Okay, so why don't we maybe start out with doing a lung cancer 101 type of thing? So where does lung cancer start? What are the different stages? Just an overview for someone listening in who doesn't know a ton about lung cancer.
Yeah, so the way I approach it with my patients is we first talk about what type of lung cancer they have. So there's generally two buckets of lung cancer. There's non-small cell lung cancer, which is the most common type of lung cancer. This is actually the one that's going to occur most commonly in patients who have no smoking history. So we'll get into that as well. That makes up about 85% of cases of what people know as lung cancer. Then we have small cell lung cancer, which tends to be a more aggressive form or subtype of lung cancer. It's about 15% of cases of lung cancer. So that's really the two sort of categories of lung cancer when we're thinking about what a patient is dealing with. When we're talking about stage of disease, that's really where the cancer is, because many times, unfortunately, over half of the patients that I meet for the first time in clinic, their cancer has spread outside of their lung. And that's typically what we call stage 4 disease. Now, our goal is to try and identify patients when they have early stage disease, because that's our opportunity for cure. to really provide a meaningful treatment and cure for these patients. And so it's so important. So that's stage 1, stage 2 disease. And really, the staple of being able to provide cure for these patients is with surgery. And then we have locally advanced disease, which is typically stage 3 disease, meaning that the cancer has moved not just from where it started in the lung, but to nearby lymph nodes, and sometimes even surrounding organs. And so that's generally what we think about in terms of staging.
Got it. And then stage 4 would be outside of the
And
lung?
stage 4, yes, exactly. Stage 4 is outside of the lung, that it's moved to a distant organ. We also include if patients have what we call a pleural effusion, meaning the lining of the lung, which is called the pleura. If there's fluid that's contained or causing issues in that space, that's also metastatic or stage 4 disease. So there are some nuances, but
Okay.
generally, if it's moved outside of the lung, we call that stage 4 or metastatic.
Okay. And the pleura, is that considered like its own organ, or is that considered it's a part of the lung but still considered distant?
Yeah, it's an external part of the lung, technically. So it's the outer lining of the lung. So normally, all of us have a pleura. It's basically the outer lining of the lung. If there's involvement either because of fluid, cancer cells in the fluid in that space, or if there's actually disease within that space, so pleural nodularity, pleural thickening, that's considered to be stage 4 disease.
Got it. Okay. So non-small cell and small cell are the two
Correct.
variations.
Correct.
Okay. Okay. What's considered a small cell? Like, is it a measurement of the cell?
Yeah, so it's not so much measurements of the cells. Typically, whenever a pathologist looks under the microscope for small cell lung cancer, it's got a very classical type of appearance. So blue small cells, and that's kind of the reason why we call it small cells. So it's not so much based on the exact size criteria as it is sort of how the cells look in general. So there's a very classical appearance for small cell lung cancer. And then non small cell lung cancer has a few different subtypes. So the most common subtype is what we call adenocarcinoma, and that's sort of the fancy name of the cells. That specific subset is the most common subset for patients who have no smoking history, which many of us think is a traditional risk factor for lung cancer. And then the second most common subtype in non small cell lung cancer is called squamous cell cancer. And so squamous cell cancers can occur in other areas, just like adenocarcinoma outside of the lung. But that's the second most common. That one is typically associated with a smoking history.
Okay. Okay, got it. Okay, well that kind of takes me into what I wanted to do next. I was hoping that we could play a little game of myth or fact.
Okay.
Um and if that's okay. So what I'll do is I'll list off like 5 6 different statements that I've come up with that I think for most of us, when we think of lung cancer, those are, what we think of. And maybe you can just go through and, say whether it's a myth or a fact and give us a little explanation of why that is.
That sounds good.
Okay, perfect. So the first one is only smokers get lung cancer.
That's definitely a myth. And that's really a big focus of what I do for awareness, what I do for research, and the patient population that I see. So I tell patients all you need to be at risk for lung cancer is to have lungs. A lot of us are really focused, anchored on this traditional risk factor of having an extensive smoking history. And that is not true. So the numbers that we're seeing now in the United States is 12 to 20% of patients have never touched a cigarette, have no smoking history, and will have lung cancer. And that's a fact that a lot of people don't know, right? They think if I don't have a smoking history, if I don't have a vaping history, I cannot get lung cancer. And that's not true. We're really seeing younger patients with no smoking history, especially females that are being diagnosed with lung cancer. And so the way that I'm teaching my trainees, talking to patients and caregivers when I meet them in clinic, is I tell them that the face of lung cancer has changed over the last 15 years. Um, Traditionally, we used to say that the average age of diagnosis was 70 for lung cancer. But patients that are 50 and younger are day by day increasing in the population that's now being diagnosed with lung cancer. So, absolute myth. You don't have to have a smoking history to get lung cancer.
Wow. I have a lot of questions around that, so we'll get into that later. But okay, let's get to the next one. Lung cancer is always aggressive and has poor overall survival rates.
That's also a myth. I think there's been a lot of history with lung cancer. So, If we go back almost 20, 30 years and we looked at 5 year overall survival rates for the general category of lung cancer, that's the way that us as clinicians, as researchers, think about how we talk about clinical outcomes for patients. We think about 5 years out from diagnosis, how many patients are still with us. So rates were dismal, 20, 30 years ago. Less than 5%, even 1% of patients were still with us at the 5 year mark. And so it was a really tough time to be a thoracic oncologist. But a lot of things have changed over the last 15, 20 years now. We've really been able to, one, personalize our treatment approach for patients. And so we'll talk a little bit more about that, what it means to personalize treatment, move beyond treatments like just chemotherapy, offering patients targeted therapy or immunotherapy that is translated most definitely into clinical outcomes that are much more improved than the past. So I would say definitely a myth. Things are changing from the treatment standpoint, but also we're really focusing on lung cancer screening, trying to find these tumors early, right? Where we can make an impact, where we can offer patients a cure. So lung cancer screening is just as important as translated to improved outcomes.
Okay, great. That's awesome. That's really good to hear. Next one, kind of related to what you said, but there's no great way to detect lung cancer early.
That's also false. Uh, I would say with a caveat here. So there's definitely this importance of lung cancer screening. So the USPSTF, along with the American Cancer Society, have released guidelines for patients that qualify for what we call lung cancer screening, which is using a low dose CT scan annually every year to follow up on and observe surveillance, rather, if a patient is at risk or is developing any signs on their imaging that's concerning for lung cancer. You have to have a traditional risk factor right now to qualify for a low dose CT scan. So, what do I mean by that? That means that you have to have a smoking history, at least 20 pack years or greater. You're currently smoking or you've recently quit smoking, and you have to have an age of 50 up until the age of 80. So, some of these criteria have been liberalized over the last few years, trying to really hone in and bring in more patients who may be at risk. But at the same time, we are still neglecting to find really good screening methods for patients that don't have that traditional risk factor, that don't have that smoking history. And so research still needs to be done in that space. It's actively being done. But right now, I would say absolutely a myth. There is a way to find lung cancer early, and we need to get awareness out there. We need to get primary care physicians involved. It's so important.
Okay, great. All right, the next one. Lung cancer symptoms traditionally always include coughing or difficulty breathing.
That's also a myth. So I've had countless patients tell me I actually feel fine. I didn't have any symptoms. We actually found this incidentally on imaging. And so at earlier stages of disease, patients may not have any symptoms at all. And so that's why lung cancer screening is so important, because when you can find a tumor when it's small, you may not have symptoms. And that's really the opportunity to be able to provide cure potentially for patients. Of course, you did highlight some of the traditional symptoms that patients may develop or may be experiencing when they're getting lung cancer: cough, shortness of breath, the really scary symptom of coughing up blood or chest pain. You should definitely take those seriously. And so I tell patients, a lot of the symptoms can be kind of vague until they become very severe. And so having a longitudinal relationship with a primary care physician who knows you, advocating for yourself if something doesn't feel right, that is so important, and it can really make a difference in your care. So both of those things I really encourage to everyone and anyone that I'm talking to.
Yeah, that's great. No, I'm definitely very big on advocating for yourself. And I think that's so nice to hear an oncologist say that as well. And not just from the patient side, that that's also something that you guys need for us to do. Quitting smoking reduces your risk of lung cancer no matter how long you've smoked.
That is true, actually. We really do want to encourage people to quit smoking. We really encourage what we call smoking cessation. It's not only going to minimize or potentially reduce your risk for lung cancer, but other cancers as well. So, smoking has been associated with bladder cancer, with different GI cancers as well. So, it's really important to reduce your risk for all types of cancers. And cutting back on smoking can really make that difference. Not only that, but we actually have data that for patients that have quit smoking, if they're undergoing treatments for their lung cancer, they actually have a better outcome. So that encourages people that it's never too late to quit smoking. You can have a better outcome from your treatments. You can reduce your risk of developing other cancers. And so I'm a big proponent of smoking cessation and really encouraging patients and families to lean in on that.
That's awesome. That's really good. Um, okay, the next one. Vaping is a safe alternative to smoking when it comes to your risk for lung cancer. And then related to that as well, vaping as well as like smoking hookah or shisha, as they call it.
Yeah, so that's false as well. I will say we're still learning about the exact link of vaping leading to lung cancer, but it can definitely have an impact on lung health. So I'll tell you that, especially during the COVID-19 pandemic, a lot of people that were vaping were also experiencing severe lung health injury. And it became a real problem. Several patients had to be admitted into the hospital, potentially even intubated to help them breathe. And so it definitely can have an impact on lung health. We're still learning about the exact link between vaping and it causing lung cancer. But really, when you're vaping, you're basically heating a liquid that has a bunch of different substances. You're turning it into an aerosol, and then you're inhaling it, and that gets trapped in parts of your lungs. Right? It's really making an impact. So it can develop inflammation. It can cause COPD, chronic obstructive pulmonary disease, and those things can really be triggers for the future of damaging lung health and potentially even causing lung cancer. So I would say, really, the safest alternative to smoking is just complete cessation.
Got it. And would you say the same for smoking hookah as well?
I
Same.
would. Yes, I would say the same thing as well. It's a very similar sort of mechanism of what you're inhaling and what you're putting into your lungs. And so, really protecting your lung health can really translate to better outcomes for you, not only from a cancer standpoint, but just in general.
Okay. Okay. Got it. Okay. Awesome. That was fun.
Yeah.
Okay, so we talked about smoking a bit. Are there other lifestyle or environmental factors that you think could contribute to having a higher risk for cancer? And what really flags someone as being considered a higher risk cancer person or cancer? What would you call it? Cancer,
A risk, I guess, a risk factor for lung
a,
cancer.
a risk factor, and what would make someone want to, see a lung oncologist or potentially go for an annual screening?
Yeah, I think these are good things. So the annual screening, like I said, is still limited to patients with that traditional risk factor of smoking outside of the clinical trial. There has been some really exciting data, for example, in Taiwan, where they have a national study that's being led looking at non-traditional risk factors for lung cancer and can you successfully implement a screening mechanism on a nationwide level. And they've done it, and they've done it successfully. So it's really exciting to see that that's out there. But for now, for screening, that's still limited to having that traditional risk factor of smoking. Outside of smoking, the risk factors that we think about for lung cancer, one is radon exposure. So it's really hard to even tell if your house has really high levels of radon unless you're testing. So this is an invisible, odorless, colorless gas, right? But it's definitely been linked to developing lung cancer. So that's a very common sort of second traditional risk factor that we think about. There's also been some work and studies that have shown that air pollution is causing lung
Mm.
cancer. And so some work has been done that's shown that air pollution in high quantities is almost waking up dormant cancer cells and mutations and causing them to grow into tumors. And so thinking about the environment that you're living in and surrounding yourself is really important. Of course, secondhand smoke exposure is also really important to think about. When we think about outside of, I know you're focused on breast cancer, but in lung cancer, we are still learning about what we call germline risk factors. So these are mutations or changes in DNA and cells that you get passed on from your parents. You could potentially pass on to your children, and that puts you at an increased risk for lung cancer. In lung cancer, we really don't yet know, and we don't really have enough information just yet on those different types of mutations. There is one mutation, but it's just not as common. What's
Okay.
more common in lung cancer is what we call acquired mutations. So these are mutations over a patient's lifetime where there's changes in the DNA of the tumor cells, only the cancer cells. So it's limited to just the tumor. It's not in your other cells of your body. It has not been passed on to children or given to you by your parents. So it's a very different subset of mutations when we talk about it. But probably the most common question I get asked is, I have lung cancer. They found a mutation. Does that mean my children are at risk? And most of the time in lung cancer, we say no.
Got it. Got it. So in the breast cancer world, right? So we've got like BRCA1, BRCA2. Is there anything comparable to lung cancer that you could get a genetic test for currently?
No, there's not, with the exception of one mutation. So the germline mutation is called EGFR T790M. So that's a very specific type of mutation that occurs in lung cancer. It's a very minimal percentage, and higher risk factors is if you're from an Asian history. Typically, if you're female, those are kind of the main demographics for that population. Outside of that, we don't have any germline screening tests that necessarily increase your risk of lung cancer and passing it within the family. But
Got it.
mutation testing, yes, of the tumor cells itself is super important, not only for guiding treatment, but also talking about prognosis of patients.
Got it. Got it. And then also, I mean, so I know in the breast cancer world, if you do have a mutation, while of course it's, that's really hard to hear and to learn about, but there's also targeted treatments if you do have a mutation. Is that similar with this germline situation that you guys are developing targeted treatments if you do have something like that?
Absolutely. And that's even outside of that germline mutation. It applies to any driver mutation that we find in lung cancer now. We're really finding what we call targeted therapies, which is exactly what you said. And so they're very personalized to the tumor itself. They're personalized specifically against the receptor or the mutation that's teaching the tumor to grow. And so we now have 9 different mutations that
Mm,
we're looking for with FDA approvals, where we match a drug to the patient's specific tumor. And the outcomes are much better than with traditional cytotoxic chemotherapy. So that's why testing in lung cancer for mutations is so important.
that's awesome. You said non-small cell is the one that is related to smoking or the one that's not?
Non-small cell is not as related to smoking history. So small
Okay.
cell is more commonly with that traditional heavy smoking history. Mhm.
Okay, but you also said non-small cell is more common?
Yep, non-small cell is more common. It's about 80 to 85% of cases.
Interesting. So does that, I guess, thinking about that, would you say that are you more likely is it more common to get lung cancer if you're a non-smoker then or not necessarily?
Not so much. So
Okay.
so if you think about in the US population, roughly about 12 to 20% of patients with a lung cancer diagnosis have never touched a cigarette, have no smoking history. So that means close to 80% of patients with a lung cancer diagnosis do have that smoking history.
Got
For
it.
non-small cell lung cancer, the majority of patients that get diagnosed with non-small cell lung cancer will still have a smoking history. But the most common, if a patient is a never smoker, they're more than likely going to have a non-small cell lung cancer diagnosis. So, if that makes sense, that really small cell is classic pack years of smoking. Really, that's the traditional risk factor. Non-small cell, yes, smoking can play into it, but if you're a never smoker, you're definitely going to be more at risk for non-small cell lung cancer. That's probably the diagnosis you're going to have.
Okay. Okay, that makes sense. I don't think I've heard the term pack years before. Can you explain what that means?
Yeah, so this is something that we always think about in clinic when we're thinking about doing a social history for a patient. We want to assess truly what is their risk factor for lung cancer from the traditional risk factor standpoint. And so we'll ask about and quantify what their smoking history is. And so we'll ask them, how many packs per day do you smoke generally on average? And then for how many years have you been doing that? And so, for example, if a patient says, I smoke 2 packs per day and they've been doing it for 20 years, that's a 40 pack year smoking history. The
Mm,
reason why it's important is because of the lung cancer screening guidelines. So when you look and see what the lung cancer screening guidelines say, they say ages 50 to 80 with a 20 pack year smoking history. So the way you can get to 20 is either 1 pack a day for 20 years you've been smoking, or it could be 2 packs a day for 10 years, right? That's 20 pack years. So just different ways to quantify it and think about that traditional risk factor.
okay. That's actually really helpful,
Yeah.
to have that. I always like a metric to use, so that's really great. Why don't we talk a little bit about treatments? So, I mean, we of course have traditional surgery, chemotherapy. I know there's a lot of advancements being made as well in the lung cancer space. Could you talk to us about that?
Absolutely. Yeah. So historically, we've been so confined to cytotoxic chemotherapy, which just non selectively is killing any of the fastest growing cells. That's why people not only have a response in their tumor, but they'll also have some of the side effects, right? Some of the really terrible side effects, GI side effects, hair loss, you name it, just these fast growing cells being non selectively killed. We've really taken a leap in the treatments that we're able to offer from a medical oncology standpoint. So now we're using a drug called immunotherapy, which has really revolutionized not only lung cancer, but the way we treat all other types of cancer as well, including breast cancer. The way I teach patients about immunotherapy, I say it's very different than chemotherapy. What it's doing is it's teaching your own immune system to recognize the cancer cells. The cancer cells are typically very sneaky. They'll wear a cloak, they'll hide from your own immune system and sort of fool your own immune system into thinking they're normal, that they're supposed to be there. What immunotherapy does is it takes the cloak off. It really shows the cancer cells to your immune system and says, this is not supposed to be here. It really shows it to the soldiers of your immune system, which we call our T cells. And then they get revved up and they get energized and they start to go after the cancer and attack it. So it's a very different approach than chemotherapy and just sort of non selectively killing fast growing cells. Then there's another bucket of drugs, and we've talked about this a little bit so far. It's called targeted therapy. And targeted therapies are different than chemotherapy, different than immunotherapy. Most of them are actually oral drugs that our patients can take at home. And these drugs, what they're doing is they're very selectively attacking receptors, proteins on the tumor cells that are being overexpressed. And that's because of a mutation in the tumor cells, a change in the DNA that's caused the cells and these proteins and these receptors to kind of grow out of control and to feed itself into growing. And so these targeted therapies will essentially go directly to the receptors that are being overexpressed on the tumor cells and shut the pathways down. So then the tumors can't continue to grow and they can really kill off not only the cancer that's there, but also help prevent new disease from forming. And so it's really exciting to be able to offer what we call precision medicine, personalized medicines to patients with lung cancer because the science has been done. We've found these mutations and we're really making a difference to personalize treatment.
That's great. I know something that I've gone through in my journey, and I think it's kind of a common experience on the patient side. So I think from the outside, people think that when you get diagnosed, that you should go aggressive, quote unquote. And that means the surgery, the radiation, the chemotherapy, the traditional chemotherapy. And I think the misconception is that if you go with a targeted treatment, that you're not being as aggressive. I'd love to get your thoughts on that. I have my own personal thoughts on that just from the education I've received, but I think that would be really helpful for people to listen to.
Yeah, absolutely. I would actually say that targeted therapy may be one of the most actually advanced, the most aggressive approaches. The response rates for targeted therapy are much higher than with chemotherapy alone because you're really matching the target, right? The cancer cells to a specific therapy that has high response rates with less off pathway toxicities. So I would say the response rates are better, and then also the toxicity is improved with being on targeted therapies. So if you do want the most aggressive approach, which is what I talk to my patients about, we talk about goals of care. We use shared decision making in clinic every single day because there's this concept of not only treating the body, not only treating the cancer, but you need to treat mind, you need to treat soul. It's such a tolling disease to have been dealt with, right? And going through it, it's more of a longitudinal experience, I tell patients, rather than sprinting for most patients. And so being really thoughtful about the treatment, not only from the therapeutics perspective, but the supportive perspective is so important to make sure we're addressing it.
Yeah, absolutely. Why don't we talk a little bit more about your patient centric approach? So I totally agree. I think cancer, it's not just about those cancer cells, right? It's such an overall holistic body experience, mind, body, soul, nutrition, all of that. What are some things that you talk to your patients about related to an overall approach?
Yeah, absolutely. So they actually did a study a few years back now where they looked to see if patients newly diagnosed with lung cancer were they going to improve if they were early on referred to a group called palliative care or supportive care. And then they compared that to patients who did not get that early on referral. And they looked to see, is the patient's quality of life better? And then also, are patients living longer? And what they found was that patients with advanced stage lung cancer, if you referred them early on to palliative care or supportive care, they not only had a better quality of life, they actually lived longer than patients that did not see that team. So that really shows you the importance of supportive care, really shows you the importance of not only the treatments that we're choosing for our patients to go against the cancer, but also all the different ways, methods that we're trying to support patients who have cancer, right? So I tell patients that all the time, that we got to lean in not only on the therapeutic side, but the supportive side. And there's data to say your quality of life is going to be better and you're going to live longer. That's huge. So I loop in my palliative care colleagues, my supportive care colleagues on day one for almost all of my patients. So that's one team I rely on. The second team I rely on is nutrition. Nutrition is so important. There's a lot of misinformation that's out there too about what diet is best for patients with a specific type of cancer, be it lung cancer, breast cancer, you name it. But the best person to answer that is really the nutrition team, the team that is focused, that has done education, that is up to date with all the resources and latest data. So I refer patients to the nutrition team as well very quickly from time of diagnosis. And then the
That's
last team
great.
I really loop in is called integrative medicine, which we have at our institution, but there's other institutions that also offer this service. And they lean into evidence based medicine, which is really important. So, really going to a team that's relying on evidence based medicine in this space is I can't stress that enough. But they're using different methods, different supportive methods like acupuncture, for example, massages, you name it, to support the patient, not only from a quality of life standpoint, but there's also great data to also say that this is in conjunction to your therapeutic approach, giving better outcomes. So, those are the three groups I lean into. And you know, you name it. I think caregivers, support groups, all the other access to resources that are available are so important to think about and share those resources with your patients.
Yeah, absolutely. I think when I first got diagnosed, so I get treated at UCSF, and so very similar. I think yeah, palliative care, nutritionist right away. That was like first week that I was there that I was connected with these people. I think when I heard palliative, I think my initial misconception was that it was more of like, we can't do anything for you. So here's people who can make it more comfortable for you. And, I've learned that's not the case. Will you speak a little bit about that?
Absolutely. Yeah. I think one takeaway from this podcast that we're doing today, if there's
Yeah.
something that we can stress, it's that palliative care is there to help. It should not only be associated with what we call hospice, right? That there's a spectrum of palliative care. So the way I talk to patients about palliative care is I say, hey, there's a group of doctors, nurses, case managers, social workers who have only done training specific to supporting your symptoms. They're the experts in symptom management. They have not done any training in the cancer therapeutics, thinking about what specific treatment is going to be best for your cancer. The training that they've done is focusing on symptoms, focusing on making sure people's quality of life is better. So how do you not want to see the experts that have trained just to help your symptoms? It's an incredible valued resource to have. And there's a lot of stigma with going to a palliative care referral, but I would say let's take that away. A lot of institutions have tried to change the name to supportive care. So if you hear supportive care, if you hear palliative care, you don't necessarily need to associate it with hospice, associate it with symptom experts, is what I tell patients.
Yes, that's great. And then I will also say on the nutrition piece, I think there is a lot of misinformation out there, as you said. And I think it's very important to speak with a nutritionist who is familiar with your type of cancer. I mean, brain cancer is very different from a nutrition space than, breast cancer or lung cancer. But I think one thing that what I've at least learned, or my take on it, is that there's a lot of similarities. I think one big thing is a plant forward diet. I think that across the board on all the cancers is something that I've continued to read, is that if you can focus on having a plant forward diet, there's obviously, you can go down the rabbit hole of how specific you want to get on what particular types of foods you want to eat, or if you want to go keto or vegan, all of that stuff. But I think for someone listening in, I think if you can incorporate more plants into your diet, I think that really does support your immune system to better fight and take on the drugs. Is that your take as well?
Yeah, no, I agree. I think incorporating protein is really important just in
Protein
general
as well.
going
Yes.
through cancer treatments. But I would say yes. I think a plant forward diet, a more focused on plant protein sources, things like that, is really important. And a lot of my patients do that. A lot of my nutritionists also talk about that idea. I myself am vegetarian, so that's a little bit of a plug there too. But yeah, I agree. I agree with that. But I also just tell patients have a balanced plate, right? Like when you're looking at your plate, it should be balanced. Like you don't need to lean one way more than the other necessarily. balanced and colorful is going to be really helpful. So fruits, veggies, having plant-based protein or other sort of rich sources of protein is important. And then the other thing I'll say too is before you start treatment, we really want to focus on making sure patients aren't losing weight rapidly. So sometimes if you just got to get in nutrition, be it whatever source it is, just to keep your weight steady, make sure you're not dropping a lot of weight, that's just as important. So I've got patients that really are drinking milkshakes quite often, honestly, and they're just trying to boost up their calories before we get started on treatment. And I'm okay with that. I think just trying not to lose your weight too rapidly is just as important as focusing on what you're eating.
Yeah. And do you think that is your concern about losing weight too rapidly is that then your body is not in a optimal state to take on the treatments?
Absolutely. And there's this concept of cachexia, cancer related cachexia, which is really severe wasting, not only from like a what your objective weight is, but just a metabolic syndrome where patients are losing their calories, they're losing sort of a lot of their metabolic function. And so cachexia, one of the ways you look at it is by the percentage of body weight that someone's dropping. And what we know is that patients that develop cancer cachexia that have a significant weight loss before they start treatment, their outcomes, their prognosis is not as good as patients who have more of a stable weight that are not going through that experience. And so that's something your doctors are actively watching. What's your weight doing before treatment? What's your weight doing while on treatment? And if you need support, don't be afraid to lean into it and advocate for yourself, request for a nutrition referral if you're not given one.
Yeah. Absolutely. I think it's so important that I mean, ideally, your oncologist is presenting you with, setting you up with these different care providers. But if they're not, I think it's so important to advocate for yourself, ask for referrals, and get plugged in with the professionals that are experts at this.
Absolutely.
Okay, this is really fun. Why don't maybe to end, if we can talk a little bit about clinical trials? I know that's something that a lot of people listening in, I think it's really big in just the cancer community in general, is what's coming down the pipeline for treatments. So maybe, and then we also have people listening in that either some people do get treated at a cancer research center, but a lot of people in our community are getting treated at community hospitals. And I would love to get your take on maybe if you can mention a couple of clinical trials or just concepts of them of what's being worked on, but also how someone listening in can possibly have access to know what clinical trials are available and how they could possibly get plugged in.
Yeah, absolutely. I think clinical trials are so important for patients with cancer. The way I tell patients about just how important they are is every approval that we have, every drug that's being given in clinic right now that we call a standard of care drug that you can get at a community center, that you can get in an academic center. The way it got there was because of a clinical trial, because of patients who were brave enough to sign up, to enroll. So, from the bottom of my heart, just first of all, thank you to every patient, every family that's ever signed up for a clinical trial because they've paved the way not only for their own clinical outcome, but for the outcomes of future patients with cancer. So that's huge and should be celebrated and commended, honestly. So thank you for that, first of all. Finding the right clinical trial for you can be really challenging to navigate on your own. There's a lot of what we call inclusion criteria, exclusion criteria, and there's really not a great place to look in one single resource of where to go, what's the best trial, and is it currently enrolling patients, accepting patients to get started on treatment. One of the things I tell patients is visiting an NCI designated cancer center can be really impactful in terms of the treatment recommendations that you have. So, if you are being treated at a community center at some point, you're interested in clinical trials, I would look up where your closest NCI designated cancer center is to talk about what trials may be available to get a second opinion because every case is different. And if at any point you're considering a clinical trial, you should absolutely feel empowered to go seek that out. So that's just generally just navigating clinical trials and why they're so important.
Awesome. And then anything specifically in lung oncology that you are super excited that's being worked on or you know is coming down the pipeline.
Yeah, so there's definitely this concept of personalized medicine in lung
Mhm.
cancer. And so, like I said, we've been able to identify now 9 different driver mutations in lung cancer or driver alterations where we're matching patients to very specific personalized targeted therapies. And so, there's been a lot more research in terms of if patients have their disease grow on a targeted therapy currently, what are we going to do next? And so there's definitely next generation targeted therapies that are under clinical trial investigation and study. So that's sort of a whole bucket or arena of different trials that are available to patients that are actively undergoing research. And then there's even for a specific mutation that we call HER2 or ERB2, which is one that we hear more in breast cancer, actually. And us lung cancer oncologists are taking a page out of breast cancer to learn more about how to treat patients. We're starting to identify and actually investigate different oral drugs against that HER2 mutation in lung cancer. And just recently, actually, at the World Lung Conference last month, we saw some really exciting information about HER2 specific oral drugs for patients with lung cancer with excellent response rates, 70% up to even 90% in patients that have already gotten treatment. So
Wow.
I'm really excited about that specific mutation. I'm excited about next generation targeted therapies. But we could go on and on talking about all the different trials that are available. But I think if you're interested, if you're even considering a clinical trial, seek out a second opinion and ask what trials may be applicable to you.
That's awesome. That's great. I think I kind of feel like, I mean, in breast cancer, for metastatic specifically, like this kind of is the golden age of treatments. And so obviously having a later stage diagnosis is, of course, very scary, but the treatments being done, the clinical trials being done, like we are in such a good space right now. And I completely agree with you. I think if you are able to participate, I think one, it is a potential new treatment for you, which could work. But then there's also this greater benefit of, these FDA approved drugs come from these clinical trials. And so the more that we can do as a community to help not only ourselves, but help the overall, treatment is really important.
Yeah, no, it really goes a long way. And it can't be undervalued or understated just how much it means when I think about what it takes for a patient, for their family to undergo, to sign up for a clinical trial. They're really advancing science and not only the science, but sort of the art of oncology too, the compassion side of really trying to push things forward, push advancements forward so we can have better outcomes for all of our patients with cancer.
Yeah, absolutely. And I think also one more thing I would say is that I think before I was diagnosed with cancer, I kind of thought of clinical trials as okay, if none of the approved treatments work, then you do a clinical trial. And that's something that I've also had to shift my mindset about is that that's not the case. You can do an FDA approved drug, then you can do a clinical trial. If that doesn't work, you can go back to other FDA approved drugs. It doesn't have to be something that's done as a, last resort type of thing.
Absolutely. I agree with that completely. We're looking at can we continue to do better than our standard of care? What's available to patients in clinic today? And that includes frontline, first line treatment options. Can we do better than our first line treatment option? And so that's what a lot of our trials are looking at. So I would say that kind of sometimes before you start treatment, if you're even thinking about a trial, that is an opportunity to enroll a clinical trial. But exactly like you highlighted, there's different entry points into clinical trials. If unfortunately a disease progresses or grows after your first line of treatment, that's an opportunity as well, or even later down the road. But yes, different entry points for clinical trials.
Awesome. Great. All right, Dr. Singhi, thank you so much for being here. This is such a great conversation.
Yeah.
I know that you are also doing your own advocacy work outside of your practice. Where can someone find you and learn about your work or just get in touch with you?
Yeah, absolutely. You can follow me on social media. I'm at Lung Doc. I am really excited about being able to educate and engage patients, caregivers, and other sort of medical professionals about lung cancer specifically, really focusing on patient education research and then also young onset lung cancer. So patients ages 50 and younger with lung cancer. That's both my clinical and research interest, and happy and honored to have anyone follow along.
Awesome. Thank you so much. Thanks for listening to The Other C Word, hosted by Bismology. New episodes drop Mondays. Connect with me on socials at Bismology, and let's all learn, grow, and inspire each other.